It is 12 o'clock somewhere, so we are going to go ahead and get started. Welcome to all of you for the third or four-week series on best care. So we have, you've heard quite a bit if you've been able to get to the other sessions, and today we're going to focus our attention on readmissions and patient safety and how they figure in our best care work. So I wanted to start with a recap for those of you who may have missed the first couple of weeks of how we got to where we are in this conversation. If you can see I know there's a lot going on in this slide, but what I would point out for you, just a reminder that the way I think Donna first, on the first week, talked with you about the overall quality and accountability report that has been published by Vizient for now since 2005, they've been at this award. You'll see on the very bottom of the slide, without the most recent year's numbers in there, our ranking and performance. So we've, at UTMB from 2005 to today, started in a back and forth thing between a 1- and 2-star hospital to solidly getting to a 3-star hospital. Last year, we saw our performance decline just a bit, and we're now at the low end of the 3-star grouping. But on a trajectory to change that course and move us to the top 20th berth. So a reminder to you, our overall rank among 102 academic health centers nationally is the 76th. We did drop a bit. We were in the mid-50s the year before. So we'd like to see that come back up. And that wheel gives you a good color representation of where the work lies ahead, or the work that we're actively working on. So as a reminder, dark red is our worst performing scores. Dr. Sharma talked with you last week about mortality. And next week, Deb McGrew is going to talk with you about length of stay and our efficiency efforts. Dark green, you've already heard us talk about equity. Also in the first week of these series, David Marshall talked with you about patient-centeredness as measured by patient satisfaction at Vizient. But today we're really going to talk about the effectiveness and safety components of those metrics, which will boil out largely to be readmissions and patient safety. I wanted to start with this slide because as I was listening to the comments of the last 2 weeks, I was reminded, many of you have heard the words high reliability or a high reliability organization or a high performing organization. Mark Chasin, who now leads the Joint Commission, well, that must have been a timed slide, who leads the Joint Commission, talked in an article about 3-4 years ago in Health Affairs about high reliability in healthcare. And he said there's really 3 conditions to get to high reliability: leadership, an engaged leadership, a safety culture, a culture in which everybody feels free to speak up and draw our attention to vulnerabilities in patient safety, and a robust process improvement methodology. So if you really want to become a high-performing organization, a highly reliable organization, those are pieces that you really need to have in play. The graphic that you see is a somewhat tired slide. I've used it for a little too long probably now, but it's to really point out as folks in other industries have measured their performance in defects in parts per million, in our defect rate, they would argue that healthcare is behind the curve. We're behind a lot of other industries in how we've imported concepts of becoming high reliable and really building in reliability. We're behind others. Beth McGlynn from the RAND Corporation did some work, really groundbreaking work now, 6 to 8 years ago, and she would say we were in the middle of that curve, that in about half the time in a patient who has diabetes, a patient who has a chronic disease and goes into the clinic, half the time they would get best known care. So half the time is not highly reliable. Half the time is not where we want to be. That's a really high defect rate. So we've got work to do if we want to become highly reliable. The reason it triggered that thought for me is in the last couple of weeks, you've heard these words. When it comes to equity, it means we're delivering every time to every patient the best known care that we know how to deliver, irrespective of gender, age, ability to pay, holding all of those things accountable. Patients should all get the same processes of care. So every patient, every time. HCAHPS, the word was always. So David pointed out to you that the range of performance when our inpatients are responding to the HCAHPS patient satisfaction survey. They're rating us on how frequently that occurred in their experience. And the overall rating of 9 to 10 really gets at their recommendation to others about how we rank as a hospital. And we're only interested in that rating of 9 to 10, the high end of that score. Dr. Sharma pointed out to you with mortality that we're really our ongoing mantra. The drumbeat for us is to get to 2% or less for mortality. So I'm trying to remind you with a little rubric that these are the things, these are the high-level words that we should be thinking about that are driving our work. Every, always, 2% for mortality. And then with documentation, Dr. Sharma also pointed out, getting to complete, comprehensive documentation of the care that's actually provided and how that feeds our expected rates of performance on a number of variables. So not using symbols, not just talking about symptoms, getting very specific, but also using linking statements to talk about how these issues in the patient's care interact and relate, and also doing things like closing out rule-outs, that we're eliminating inappropriate documentation when we finish the documentation by saying when we've resolved an issue, it's no longer active, and being clear that everybody understands that. So there's a new mantra that we're going to run by you today, and it is this one. So what was missing? 4 and 3. So the numbers were 5, 2, 1. That's your new mantra for the day. So today we're going to talk about readmissions and patient safety, and we're going to talk a little bit about what 521 means. We'll get to that in a second. On the patient safety practices, readmissions, we're going to talk in detail about it. Patient safety, we're going to talk in detail about both what makes us safe, how Uvizient measures safety, and what you can do about it, or what you're already doing about it to help us stay as safe as we can be. I believe Don also shared this slide, so I'm just reminding you that our first quarter results were very favorable. If you weren't really understanding it, we set extremely aggressive targets for us this year. There is no way we would go from the 76th spot to the 20th spot in the Quality and Accountability Report without setting aggressive targets. You also know that these targets are incremental. Each quarter, the target moves while we're moving for many of these measures. So while we're getting better, so is everybody else. And we aren't going to hit that ultimate aim unless we hit each of these staircase targets to get to August. But you should feel accomplished, and you should be patting each other on the back. We've made very good progress in the first quarter. We've hit our targets in all but length of stay. We're going to hear more about that from Deb next week, and it's been a very challenging target. So the good news is we're getting there, but also she reminded you in the column to your right, the target's jumping up in a few measures, so that our work only gets harder. And what do you know about getting to the end? The last couple miles, the last little bit, is sometimes the hardest to get. We may have done quite well, and we may have done some of the easier work, even though it doesn't feel easy. That last little leap to get us to our ultimate goal may be the hardest yet. So we have to stay on the work that we're at. I want to put in context, why are we focusing on readmissions? So a lot of our best care work this year was promulgated by the Quality and Accountability Report from what used to be called the University Health System Consortium, UHC, now called Vizient. So in the Vizient Quality and Accountability Report, readmissions are half of that domain on the wheel called effectiveness. The other half is core measures. We've historically done pretty well in core measures at UTMB, and so if we hold our gains and we hold where we've been with core measures, we're in good shape. But we have to improve on the readmissions side. The way it is evaluated or assessed for us, they're taking the domain called effectiveness, the half of it that is readmissions, and they're spreading that across 10 service lines and one bucket called non-core service lines. So it's almost everything else. So those 10 service lines represent 70% of the weighting for readmissions. The non-core service line, GLUMP, represents that's a technical term, GLUMP, the other 30%. We are currently, as of the fourth quarter of 16, in their assessment, in their attribution to us, ranked 47. That's actually an improvement for us. So we need to keep moving to move that needle better than that. Wanted to also introduce, though, that quality and accountability study is an important driver for us. It's not the only driver for our attention on readmissions. I think there's some folks in the room who would tell you we've been working on Project CARE, on our readmissions work, for quite some time, and we did it before we even started launching the Best Care work this past year. If you weren't aware, one of the value-based purchasing efforts from the Center for Medicare and Medicaid Services is that they put us on the hook for something they introduced 3 years ago called the Readmission Reduction Program. The Readmission Reduction Program evaluates our readmission performance against all other hospitals in the country and gives us, just like we've been talking about an index or an O to E ratio of 1, they're calculating where do we fit in the array against all other national providers. That rating, that calculation of the readmission reduction factor, which is done on only a handful of diagnoses, it's not readmission across the board, it's less than 5 diagnoses. That netted us in 2017. So in all of our reimbursement from Medicare from October of 16 going forward for this year, it netted us a just under $700,000 penalty. I don't know about you, but $700,000 could go a long way for us. So anything we can do to move that readmission up also pays us. It's good business sense for us. For those of you who are here from women, infants, and children, you also know that 3 years ago, the state of Texas Medicaid program launched its own value-based purchasing exercise. And of course, you're right, the way they calculate readmissions is different. So they're using 3M software, calculating for us something called potentially preventable readmissions, potentially preventable complications. On the readmission side and the complication side, this past year for Texas Medicaid, starting October going forward, the good news for us is we got no penalty. 2 years ago, we had a $3.5 million penalty, so it was salient. That was a lot of money. They've worked very hard in OB. You've moved the needle. Thank you. We'd like to keep it at no penalty. Any questions about value-based purchasing before I keep moving? This just outlines for you, again, I said it's only some diagnoses on the readmission side. So you'll see here that it's pneumonia, heart failure, myocardial infarction. They added to the mix total joints most recently. That wasn't there before. COPD and CABG. You'll also see that in years fiscal 14 going forward, our penalty has grown. We went from 78,000, and it's grown for 2 reasons. One, they keep adding more diagnoses, and one, because they also add the percentage of our total book of business that is Medicare that is at risk. So it's gone up for 2 reasons. It isn't just that we keep getting worse, it's that they add more diagnoses and the amount that they're willing to penalize us has gone up. So it's salient. This was our last report for PPRs. The big number that we're happiest about is that right upper box that says the total reimbursement reduction at 0. But you'll see that they calculated an expected PPR weight and an actual PPR weight, and that's what got us to where we are. There was a separate report just like this for complications. All of that has saved the organization quite a bit of work. It was a lot of labor on the part of the OB folks, but they've done great work. I won't single any individual out, but there was a team working on that very hard for us. So back to Vizient, because you've heard about the dollar reason for why we should care about readmissions. But this is the array of each of those domains and our yellow bar against the gray bars of all the other academic health centers who are also working. There's a room where somebody's talking just like this in our other 101 peer colleague organizations where they're doing similar work. They want to move the needle up, and for every move they make to move it up, it makes our move yet that much harder. So what we're pointing out, and you saw with first with David and Donna, on the equity and patient-centeredness, we've been in the top quartile for the last 2 years. On equity, it looks like we're not way up there, but if you really examine that array quickly, we are tied in first place with something on the order of 70 plus organizations out of that 102. So there are a lot of people who enjoy our status in the equity side. We can't make a bunch of improvement there. We're already tied for first. Where you do see our greatest opportunities, again, is in mortality efficiency. We're going to talk today about effectiveness, which is core measures in readmissions. It's sort of middle of the pack. I told you 47th rank. We need to move it up. And our patient safety, we saw a nice increase in 2016. So we did go up. We've improved slightly in safety, but in order to get to the 20th birth, we have to get better yet. This is your squintometer eye test. The way to follow this is I told you there are seven service lines on the left-hand axis, if you can read them. I'll read you quickly a couple: cardiology, CT surgery, GI, medicine general, neurology, neurosurgery. Every one of those rows, every one of those service lines is its own, it's competing against itself, and its weight is equal with the other service lines in coming up with that 70% reduction. The graphic on the right, Vizion's approach, is they split everybody's performance into octiles. So you're seeing little teeny blue caret arrows that are telling you where we are on that continuum of those 8 octiles. Who wants to levy where we need to get? Somebody guess. Where do we need to be? Green would be good. That's a good indicator. We've done some reverse calculation, and if we could just move all of our needles to the midpoint, we would compete very favorably. So we're not asking everybody to get to the 8th octile, the best performing status. We need everybody reliably to continually deliver at least at the midpoint. So what you can see on those carets is we've got a couple of service lines where we've got a little more work than others on readmissions: cardiology, CT surgery. Oncology is sort of on the cusp. We'd like to get to that about 4.5 point on the octiles, and that's where we'd like to be. Vascular surgery's got a little bit of room to go as well. So I told you they're equally weighted, so we can't afford to only focus on one thing. We have to focus on each of those service lines, but we really also need to focus on where there's the greatest delta, the greatest opportunity to move up to the midpoint. Any questions on this one? So let's reliably get everybody at least to the midpoint and above. Here's another way of arraying that same data, but I've only pulled out the readmission data here, and what you'll see on the far right, these are quarterly scores of how we've most recently done in the light green. In the dark green is accumulating those 4 quarters, because the one thing you see, for instance, on readmission, we are going to be we're currently evaluated in this 2016 report on discharges from July of 15 to May of 16. Right? So in that 16 report, what that should tell you is for the 17 report that we're going to head into, there's a delay. So there's going to be a lag. We will be evaluated on cases that will be reported on next September, on cases that won't complete until this middle of this coming May of 17. So there's always a lag in these data. We currently go out to the Best Care website. You'll see our current project dashboards. You'll see our current performance, because it's our current performance that we really need to focus on. However, where we've started, you'll see I've highlighted in pink near red the areas where we had the greatest opportunity: vascular, cardiology, CT surgery. We're sort of on the cusp with oncology, and we need to hold our own with the others. That's really the focus for how we use that. So let's talk a little bit about what's been done at UTMB, what we still have to do. While this is a busy slide, what we wanted to convey to you is you've got a number of members of the Readmissions Project Care team here who can speak more eloquently to all of these improvements than I. But we started back when we were working with DISRIP efforts and brought in, Dr. Sharma brought in the Society for Hospital Medicine's experts, subject matter experts in readmission, where they had been running collaboratives in improving readmissions in hospital settings, and identified what they saw to be the best known evidence, best practices that were getting traction. So we started way back in 14 implementing things like Teachback, implementing assessment of risk of patients for readmission, as we talk about it as the 8 Ps. So you'll see across the board, we've done a whole host of things. We've modified changes in EPIC. We've improved the after visit summary that goes home with patients so that they have the information they need when they get there. There's been care transition education done with house staff, with residents, with nursing, Teachback with nursing. You'll also see that in more recent times, in January of this year, there was work done also with DISRIP, working with our community health program. How do we better implement interdisciplinary models of care? How do we better connect our inpatient work with our community-based case management, identifying those patients who Dr. Sharma and the team call hospital-dependent patients. We know those patients who, between their use of clinics, emergency department, urgent care, and hospital, seem to heavily be users of our system, and not always the best part of the system, the one that would perhaps keep them out of the hospital. You'll see recent gains like hiring CHF educator. We have been working in documentation improvement and in DRG assignment to make sure that everybody knows the relationship between length of stay and DRG and what that means for readmission. We'll talk a little bit about balancing measures in a second. So an awful lot has been done. Most recently, and the newest on the block with that, is two things. We did take advantage of Epic's registry creation so that hospital-dependent population is now identified in Epic, and we can use that to both track, but we can also use it to flag people's attention in the Epic product so that we're identifying patients as they present. We also have a new warehouse package we're going to spend a little time looking at called the Readmission Explorer. Those Project Boost tools from the Society for Hospital Medicine are all right here, and what you see highlighted in red is what the team's already implemented. So that's a lot. Both identifying the risk the patient has for winding up back in, making sure that we're engaging the patient to fully understand how they self-manage, helping with medication reconciliation. There's some work happening with pharmacy right now to focus some pharmacy attention on med rec with our hospital-dependent population, but also working to make sure that patients who really need to get in and get seen shortly after discharge from the hospital are getting an appointment and making and keeping that appointment. So 5-to-1, what did we say that meant? So 5-to-1 means, and this is coming right out of the work of Project CARE and the Project Boost efforts. We need, for an effective readmission program, for effectively us to be able to prevent a readmission, the belief is we need 5 interventions used by at least 2 providers, 2 agents in our care, and one of those interventions has to improve patient capacity. So look at the 5 interventions. This isn't the only suite or the only set of options, but during planning, during poker rounds, during discharge planning, and actually even in the reviews that we're now doing around root cause analyses for readmissions, we should be asking ourselves, what were the 5 interventions we tried? What worked? What didn't work? But are we at least trying 5 different things? Anybody want to venture? Why do we need 5 things at any given point? Somebody's going to be brave. I know it. Why would 5 interventions be better than 1 or 2? Louder. Sustainability. Are any of these patients complex patients? If this were easy, if we could have gotten by with doing one thing, it would have happened a long time ago. So the 5 interventions mean we've got to get at it from multiple angles. There are multiple reasons for why a patient winds up being back in. We can't afford to assume that one of those is going to be the one that works. So we need to take on the complexity of these patients' care and really work in as many ways as we can to increase the likelihood that that's going to be effective. 2 providers means this can't all rest on one person's shoulders. We need the whole team working on behalf of the patient, but we need at least 2 people actively working as agents for this patient's success on getting home and being able to self-manage. And one of those has to improve patient capacity. Well, teach-back, in essence, improves patient capacity in some way because it increases their knowledge. Anybody want to venture other examples of how we improve a patient's capacity to actively be engaged in their own self-care? So discharge instructions gives them a tool. Does it actively engage them? Do they understand it? Did they put it in the can on their way out the door, in which I would say it failed, it didn't improve their capacity, but it really has to engage them. In the ambulatory world, they use words like patient activation. If you're a patient with asthma, how do we activate you to be actively engaged in your own care, understanding your illness and what your triggers are, what you're going to do about that? community health programs done a great work, a bit of work with the Shop Till You Drop program. They were working with patients with diabetes to be better purchasers of their own groceries, know and be better able to shop and buy groceries that are going to up the chance that they're going to be able to maintain their blood glucose where they are. That's a great example of patient activation and improving the patient's capacity, being actively engaged in their own care. So what you'll see if you go out to the Best Care web pages is we now have project dashboards. The project dashboard for readmission at the top includes some elements that are leading measures, things that we're making sure on a regular basis all the time that we think have the likelihood of getting us to the better outcome for readmissions, and these are examples of them. So our 8P completion rate, we've worked between nursing and care management to make sure that on intake, more than 90% of our patients, so over the past 6 months, average of 90, almost 90, well, just over 91, that all of our patients are being assessed for the risk of readmission using the 8P system, and it's documented in Epic so that everybody knows these patients at risk. They also use I think, Dr. Sharma, we draw the line at about 4 Ps to intervene. 3. So that 8P gets actively used. So we're documenting, communicating it, and using it as a trigger. Our teach-back completion rate is also well above 90, so we're really reaching to the patient to assure that they're understanding the teaching that's going on while inpatient and are better engaged, better able to understand their disease and the care management that will be required after they discharge. We've also been working on appointing, and this is also a complex process because in our urge to hurry up and get the patient discharged, we've not always done a great job of finding an appointment that the patient is likely to keep. We've sometimes just been getting them an appointment or helping them empower them to get their own appointment, but then not always making sure that the patient got the appointment. So we're tracking on the leading measure end the frequency with which that patient leaves with an appointment that they want is where we need it to be, and that also they make those appointments. So how do we make sure they're following through and getting to it? And I'm sure all of you could tell stories on every one of these about how challenging this is. So those are the leading measures. I want to talk very briefly about the Readmission Explorer that recently has been implemented. So show of hands, anybody heard of Health Catalyst or UTMB Discover? So we've done some work on the development of a warehouse, internal warehouse. We already had some warehousing going on at UTMB, but we've worked with an outside organization called Health Catalyst, and we've branded our new warehouse UTMB Discover. One of the applications that's come right out of that early work is the Readmission Explorer, and it went live in December. We've so far rolled it out with training to just under 70 people, and hope to see it grow and become a useful tool. On the left hand, this is a screenshot from that application. On the left-hand ribbon bar, it just gives us a way to filter so we can focus our attention on some key case types and a time frame. We can look at, we all hear the multiples of ways people measure it. So 30-day all-cause readmissions, you can actually narrow the field down and look at only readmissions within 3 days, 7 days, or group them and look at all cause within 30 days. You'll also see in the center of the boxes an immediate already focus on those high-risk readmission case types or DRGs that have a high propensity to get readmitted, and how are we doing on those? So these are actual UTMB data from the date of the screenshot. It's updated nightly, so these are as fresh as we can get. This specifically took the top row on hospital-wide readmission rate and drilled in, so you see our performance over time. We want to see, what do we want to see in process improvement? We want to see the variation reduce, and we also want to see that mean go down. That's where we're aiming. Those last 3 data points are purple because you can't trust them. Readmission measures happen because enough time has to have elapsed for a patient to have had a readmission. So that's not going to stabilize in a 30-day all-cause readmission measure until we're at least out 45 to 60 days. But it allows us to look at performance over time, which is crucial if we really want to understand where we have opportunity. Here's the heart failure run chart. Each of those gives us a window into how well we're doing. This is the overall 30-day all-cause readmission metric we've been evaluating at UTMB now since 2014. You'll see that you'll see a couple of breaks in our measure of midpoint based around times when we implemented some key changes. So, for instance, the 8P getting printed on the AVS, the interdisciplinary model of care, POCA rounds, and we want to see that number to continually go down. So we're making progress. When we started in the best care conversation, we had already reduced our overall readmission rate to about 1.7%. And Donna admonished us all that we need to push our foot on the gas and move that faster. And that's what we've been trying to accomplish. So we've talked about all the gains in terms of progress that's been made. Probably the one I haven't mentioned is with the high-frequency user population, our hospital-dependent population, we've also partnered with family medicine and internal medicine in their primary care settings to identify how can we better get a handle on these patients? How can we use that registry we've just deployed? And how can we actively be managing these patients so that we decrease the likelihood that they'll show up in the ED and want to get readmitted? And now all of you have been involved, many of you have been involved in root cause analyses about each and every readmission. We want to learn from each one. So remember that CMS believes every readmission is a failure. A failure to what? A failure to plan, a failure to do some things before the patient discharged. What's the likelihood that we're going to get our readmissions to zero? Ain't going to happen. That would probably be bad care in some way. But we need to make sure that we're avoidable readmissions. We are avoiding every way we can and catching them appropriately. I've stolen these slides from Dr. Sharma, by the way, so I should probably credit him. The balancing measure, for those of you who have been through the CS&E course, you know, we ask you to really focus on your aim statement. We also say you almost always should have a balancing measure. So if we really got good at readmissions and dropped that number down, is there an unintended consequence? Because what we know about systems is if you push in the balloon in one place, it's likely to go out in another. So we should be looking at, while we're driving down our readmissions, that we're not increasing lengths of stay. In order to accomplish that readmission goal, we can't make length of stay worse. So we've got to keep our eye on balancing measures that will look at the whole system. There are some additional interventions that are being planned and will be utilized to improve readmissions. One of those is to hire a pharmacist, as I said, who will help manage medication reconciliation, especially with the high-risk population. Fully implementing and sustaining 521 after today. You have no excuse for not knowing what 521 is. And when anybody asks, it's what? 5 interventions by? And one of them has to engage the patient and increase their capacity. So 521 is our mantra. They're going to be using it in RCAs. They're going to be using it in POCA rounds. We're going to be using it to try and drive our attention that we're really paying attention to that for these patients. We're working very hard on the appointing process to make sure we get patients back in appropriately and an appointment they'll keep. And we'd like to see how we can use the new tools in the warehouse to help us do that work. Any questions about patient safety before we move forward? Or I'm sorry, about readmissions or challenges? All right, we're going to shift gears a little bit. Remember the other, a little more green is the patient safety side. But we were not quite at the 25th percentile. We need to keep working on patient safety. I want to first, hands by your buzzers. So I want you to answer the question, how do we keep our patients safe at UTMB? Education, patient education, okay? Staff too. What else? What do we do to keep our patients safe here? There's no right answer. You know a lot of this. Go. Loudly. Communication among each other. So one of our highest frequency PSN event types is miscommunication. Good point. Barcoding. How do we use technology to decrease the likelihood that we'll make a human error and we'll actually identify patients, identify products? What? Eliminate distractions. So back in the day when I had to do math to deliver a medication, you know, I'm easily distracted. We'd work hard at trying to create medication rooms where people can focus so they're not getting pulled on to do 12 things while they're working on something. distractions can be a big problem. Other ways we're keeping patients safe. Good provider documentation, because the next provider of care may not get much unless you tell them what was actively going on with that patient and what do they particularly need to worry about in the next transitioning care. All very good examples, how we keep patients safe. Next question, though, is how does everybody else measure safety? So Vizient has a way of measuring patient safety and attributing to us. I've thrown a couple up on the board. We've done all of this. So we measure our AHRQ, Agency for Healthcare Quality and Research, culture of safety. We've done it about every 18 months to 2 years and tried to use that to drive change. Meaningful use has gotten kind of a bad rap. Nobody likes to hear that word, but in the incentive programs that the feds put in place to enhance the use of the electronic medical record, the intention was that with good clinical decision support tools, we will improve care and reduce safety problems. So we'll eliminate abbreviations, we'll eliminate illegibility, we'll eliminate some things with the EMR that improved our care. Another way we measure complications is with health-associated infections. We've been long participating at UTMB in the NHSN system through the Center for Disease Control and comparing our rates of infection to other hospitals. And then finally, the feds have really evaluated us with hospital-acquired conditions and patient safety indicators, HACs and PSIs. These are largely based on the notion that there is good evidence today for good processes of care that will prevent a urinary catheter infection. So if we were doing everything we should, that should be preventable, and it should be considered a never event. So that's been translated to measures. How frequently do HACs and PSIs show up in our organization? So Vizient specifically has made choices about how they're going to attribute that. So for that, I should know this answer, Adam, 25% weight for safety? 25% weight for that domain, safety domain in our overall wheel. Of that, it's going to be made up of a number of things. These are the number. So it's measuring our standardized infection ratio, SIR, for Cowdy-Clabsy surgical site infection, and you'll see there'll be some changes with that, and C. diff. VTE06 is just mumbo-jumbo, but it's venous thromboembolism events, and it's a core measure that's been around for some time. So it's are we implementing processes of care to reduce the likelihood of a VTE? PSIs are very specific patient safety indicators that are dependent on coded data and are derived from ICD codes. And then last year, Vizient added total joint complications, which is an amalgamation and a rewrite of even some of the ones above it, but specifically for total joints. Same thing as you saw before with readmission. You see fewer little diamonds that are in the red, not in the green, but we have areas of opportunity. So we had, and I would also argue, these are a bunch of numbers and SIRs and percentages and weights. One of the things you should pay attention to with the safety domain is we're mostly talking about rare events. These are the few complications, the few issues that arise. But how we're evaluated is how few ours are compared to how few everybody else's are. So they're still looking at a rate or an ODE ratio about how often do they happen in our environment. So for us, the big work has been on postoperative hemorrhage or hematoma, postoperative sepsis, and then as you see at the bottom are hip and knee total joint complications, which are also infections and mechanical problems. Same grid, all it simply points out is we had scores of 3 for hemorrhage and hematoma and hip and knee complications, and score 4 for pressure ulcers, hemorrhage and for pressure ulcers, post-op respiratory failure and sepsis. The dates on this also mean that there's often a lag. So our NHSN data takes a little while to get scrubbed to be in. There's often a lag on these performance data, and so our leading measures really need to be focused on things like hand hygiene, the use of processes, and the things that lead us to those ultimate ICDs and codes that translate into PSIs. The Infection Control Committee is actively looking at these data on a monthly basis. When I said rare events, look at the column that says number of CLABSIs. So the number of central line bloodstream infections, we had 1 in the MICU in the month of December. These are rare occurrences. These are little 1 and 2 and 3 event one-offs that add up, because if they don't occur, it's how it affects our SIR. Also in the NICU, they've done a tremendous amount of work, and last year reduced, I don't have the number on me, but trust me that they had a patch of time where they had a number of central line infections. They've worked very diligently on line care, and they've brought that number way down. So you're seeing very few. And in the neonatal side of things, they evaluate it by risk in terms of the patient's birth weight, the baby's birth weight, and their maturity. In med-surg, we're also calculating CLABSIs, and again, very few. And then also at infection control, they're looking at organisms, patterns. Was this preventable? Why did it occur? How long did the line stay in? And it's really a function of line days. So leading measures are really focusing on the things that are within our control. One of the other really helpful slides is weeks since last bloodstream infection. So PICU, the blocker burn unit only went for, Jason, I don't know, how long did you go? What was your best, do you remember what was your best week since? It was way up there. It was years. And it only takes one to start recount. It sets you, your reset goes back to 0. But these are rare events, and we're starting to count them in weeks since, in other ways of looking at them. All I'm going to quickly do is say urinary tract infections, similarly, small numbers, we're counting them, we're locating them, trying to identify the patterns for how they exist and what we can do about that. C. diff, the very good news for us is that we enjoy a performance rating well above what many other hospitals around the country are reporting through the NHSN program. So community hospital-acquired or hospital-onset C. diff, which is our biggest issue, we see some pattern and spike, but we're largely able to keep this down. And again, good hand hygiene is one of the best things we can do to prevent that from occurring. This pink and purple, the only reason I colored them this way is to remind us that what's in pink are purely Vizient measures. What's in purple are measures not just in Vizient, but they also figure into the value-based purchasing program from CMS. So we get a double whammy there. It's not just Vizient, it's also Medicare that cares about them. Now look at our performance by quarter over time. Once you add all of these up, we were running in the range of anywhere from 7 to 12 per month. Most 2 recent quarters, we're bringing that number down. We want to keep bringing that number down. And I would really point out for you that things like hemorrhage and hematoma, this took getting clinicians, documentation specialists, and coders in the room to really talk about what's the documentation that's being put in the record, and what do the coding guidelines require our folks to declare. So we had to increase the communication between those who were writing the words and those who had to create the codes that ultimately turn into a PSI, and make sure that we're not hurting ourselves by misdocumenting or under-documenting, if you will. There are changes, of course, the rule book changes, so the only changes to patient safety for the coming years, they're taking that SSI value and they're only going to focus on surgical site infections for colon procedures and abdominal hysterectomies instead of a roll-up, because that's where the variation is as they examined it nationally. So we're going to get more specificity in that detail. So in rolling this up, again, 5-2-1 for readmissions, pretty easy to remember. And on the patient safety side, if we simply follow best practices, implement evidence-based practice, we are highly likely to increase our performance with patients in reducing the likelihood of them having a patient safety event, and then ultimately improving our score performance as well. If you have not yet been out to the Best Care website, everything you've been hearing for the last few weeks is on the Best Care website. There is if you look at the left-hand ribbon bar, you're going to see a project dashboard here. If you hit that project dashboard, it's going to take you directly out to the static charts that we have for each of the domains and give you an opportunity to look at how are we doing in each one. So if you want to stay on track with how are we doing with readmissions or patient safety or any of the other domains, that's really the place to look. I'm going to pause and just see if there are questions. Anybody else who wants to add anything I've left out that is important, or challenges that you have about what you heard? or recommendations that we might want to consider for change to continue our strides of improvement? Jeremy.
As we start thinking about, as we start thinking about bundled payments and being paid for episodes of care, are we starting to look at 90-day readmission as something? I know we're much more focused on the acute 30-day because that's where it's all at right now. But as we start moving, I'm just wondering if that's on our radar especially for some of the things that they're really starting to focus on bundled payment.
We've really been heavily focusing. There was a time at UTMB where we really only looked at readmissions under 15 days, with the assumption being that there was a better likelihood that if the patient readmitted within 15 days, there was something we could have done about it. But we've necessarily opened our window to 30 days because the feds have said that's where they need to focus and that's where our penalty is. But Jeremy's question really is, are we also looking at opening that window up a little more broadly? Because what we learned under the Affordable Care Act is the feds are interested in looking at bundling care. That bundle will be not just what we did in the hospital, but it will be post-acute care as well. So they'll bundle pricing for joints, they'll bundle pricing for certain disease types. They will take everything associated pre-admission to that inpatient admission to all their post-acute care into one price tag, which we'll have to figure out how to share. And as Jeremy's pointing out, readmissions during that window of the bundle, we will have to eat. There'll be no payment for that. So no, I don't think we've had immediate plans, Jeremy, to look at that 90-day. We have started some initial work. Dr. Sharma, David Connaughton, we're working on 4 bundles internally. One of those was total joint, I think you know. But for us to survive under that kind of future, and the total joint bundle is being tested in very numerous areas around the country right now, we're going to have to make sure that we're really looking at the whole picture and reducing total utilization. Great question. Other questions, pushback, requests? Thank you very much. And remember, next week, length of stay.
UTMB Health, working together to work wonders.